I'm Glenn Wood.
And I'm Richard Tadamir.
We're psychotherapists based out of British Columbia, Canada, and you're listening to Deliberating Practice.
In this podcast, we deconstruct everything from the foundations of therapy to its newest innovations and horizons.
We take a critical perspective on contemporary issues that affect therapists across the world. We share our own stories, both personal and professional, and sometimes we talk to other therapists too.
We hope that this podcast can be like sitting with the trusted mentor you always wish you had, helping you integrate and make sense of our complex and exciting field.
So sit back, relax, and enjoy the episode. For resources, show notes, and to work with Richard or Glenn for supervision, consulting, or counseling, go to deliberatingpractice.com. Good evening, Richard.
Evening.
Good to speak to you again tonight.
You too.
We've got a really interesting episode planned tonight, don't we?
I think so. I think we're going to get into the nitty gritty and be a bit controversial.
What are we going to be talking about tonight, Richard?
So we're going to outline two big paradigms of psychotherapy and pull the veil out from them of symptom management and the medicalization of therapy, and this other veil of healing transformation. So depth therapy, we could define this in a lot of ways, but a humanization of therapy, a ability to go into suffering, to be okay with not changing every aspect of it, versus, okay, you're anxious. How do we get rid of your anxiety, so to speak?
Right. Yeah, stemming from our previous discussion where this topic came up, Richard, you and I, we understand this, our contemporary psychotherapy world as operating within these two divergent perspectives. And I would hate to characterize them as equal in our minds or let the audience assume that we see them as equivalent approaches, because we don't. But they're certainly out there. And certainly I would say at least the information that people can access in popular media and the approach of a great number of counselors and psychotherapists across the world emphasizes symptom management. And you and I kind of want to make the case tonight for another way of approaching psychotherapy, one that is perhaps a little bit more complex and less amenable to a simple understanding, but is tremendously more valuable.
A hell of a lot harder and a hell of a more richer.
That's right. So that's the case we're going to try to make tonight to our audience. And so we'll spend a little bit of time maybe at the beginning here talking about what we mean by these two approaches, but then we'll move into some case examples later to give everyone a sense of what we really mean. So we'll look at clients that you and I have actually practiced with, scenarios we've encountered, and ways we've approached versus how we'll look at them from the symptom management perspective first, how they might be kind of conventionally understood. And then we'll look at the moves that we made that maybe supported a higher order transformation.
Sounds like a plan.
So, Richard, what does symptom management and healing transformation mean to you?
And I think symptom management is, I had a great supervisor that described this, the medicalization of normal or common human experience. And everybody gets anxious. Everybody has moments of fear. Everybody has moments of low mood. Everybody has a dark night of the soul sooner or later. And what we do in Western society is, how do we get rid of this feeling as quickly as possible? That's the striving for a pill, for a quick fix. Neither Glenn nor I are against medication, but I think we lose a lot by not understanding what might be causing the symptom, what might be causing the suffering. And many times when we treat the symptom alone, other symptoms pop up. And long-term, things tend to get worse. Coming from my now over a decade of being a therapist and several years now of being a supervisor and university instructor and for counseling, I see this. I see many examples. Yeah. What about you?
Yeah, I'm right there with you, Richard. What you just said brings up in me this idea that there seems to be in our society a place for suffering now. There seems to be a kind of basic tolerance for it within the medical or healthcare literature. I feel like one of the perhaps the only benefit of a medicalization of suffering is that it has had a destigmatizing effect, that people are more likely to come forward and be vocal or explicit about the distress that they do experience, which has not been the case, I think, for generations past. But I think though there's this sense of, oh, well, yeah, I get depressed sometimes, or, oh, I've been anxious about things like that before. There's this idea of like, well, okay, you've got the distress. It's a normal thing, but there isn't an attention to the personal significance or meaning of the distress for people. Distress isn't seen as meaningful. It isn't seen as significant or as indicative of anything. We tend to just go, oh, you've got depression. Okay, well, it's normal to have depression. Yeah. And let me give you this technique or this tool to kind of get out of it. In contrast, taking of the perspective of a healing transformation, we might look at distress as meaningful, as signifying of something for a person. I've been really into depth-oriented brief therapy lately. And the terminology they use is that symptoms have an emotional reality. And so it's essential that we get to the emotional reality of the symptom. There's a place in everyone where the symptom actually makes sense or has value to someone or is meaningful in some way. And until we get to that place, we can't really help people. This is kind of the perspective that I take in. That's consistent with my understanding of healing transformation, is we actually have to go into the distress, into the world of the distress, and understand its meaning for the person before it can be transformed.
So what would be, for our listeners, a possible example of a symptom being meaningful or having a function, purpose?
Right. Okay. Let me just conjure up one most recently. The example, I could give an example from the book I read about depth-oriented brief therapy, because they had some really good examples. Yeah, the one that's coming to mind for me is that there was a woman that had come to the therapist, and what she was experiencing was agoraphobia. So she had a lot of anxiety about leaving her house, and she had really reduced her lifestyle. She wasn't going out much. And every time she did go out, she was inundated with a lot of anxiety. And when the therapist she was working with started exploring that with her, how it came to be is that she had a lot of anxiety because every time she left the house, she would be flooded with this sense that her therapist, her former therapist, who she used to work with, was watching her, was kind of nearby and watching her. And so for this woman, the agoraphobia was kind of secondary to this other experience, and this other experience was really seen as a sign that she was crazy or something like that. So she didn't go out because she went out and she had this experience, she would feel crazy and worried she was crazy. Yeah. And so she wouldn't go out. Going even further with this therapist really explored why she would feel that way in the first place. If she were to go out, why she would feel that her therapist was watching her. Yeah. And what she learned was that this woman felt tremendously alone inside. I think she had a history of neglect. And perhaps in her present day context, she was also lonely. And so there was actually a sense of, I need to feel like my therapist is watching me, because if I don't, then I feel tremendously alone. And it was the aloneness that was the experience that was challenging and intolerable. And it was the aloneness that she needed to go to get to a place where she could feel better and more resolved. And so you can see how it went from a situation of, I have anxiety, and you could imagine, Richard, and maybe we should, how a symptom management approach might attend to that.
Indeed,
But the anxiety was secondary to a different experience and ultimately stemmed from a sense of loneliness.
Yeah, on the surface level, somebody untrained or in a more depth-oriented, more, whether transpersonal, whether, as we call it, healing transformation model, would, and I'm thinking about even really early on in my therapy experience where it was so symptom management, it was so CBT, the settings that I was in, some of the training that I received, not necessarily even from, certainly not from all the professors, but was just common in the field at the time. That was that would be seen, oh my goodness, like your therapist is watching you. You must have some symptoms of psychosis. You must have
right.
a delusional disorder on top of your anxiety, right? And, we should step up the level of care, refer her to psychiatry, something, and would be the process. Probably she would go on antipsychotics because nobody explored the function of, well, why does she have these symptoms? Could they actually be adaptive? Maybe they're not, to call them symptoms is almost offensive in a sense, right?
Right.
They're survival adaptations for her and actually give her a lot of meaning and an ability to maybe get through a situation where maybe her alternative could be total isolation or suicide even.
I like what you said there, because I think that's a hallmark of the kind of approach that both you and I are advocates of. The understanding that the kinds of things that are often assigned as symptoms within people's experiences are often, or I would say almost invariably, adaptations. Yeah, to a more difficult reality.
I think one other really common example would be depression, anxiety. Often we can be struggling with anxiety for quite some time. We're trying. Anxiety is kind of this high energy state, often where we are struggling for solutions. Maybe we're attempting different solutions. They're not having the effect that we would like. And there's this feeling or image of banging your head against the wall, trying the same thing with the same result, which is not much, it feels like. And then and I had a really great prof who was an existential therapist, influenced a lot by, anyone wants to look up existentialanalysis.ca, great organization around meaning-centered therapy.
Alfred
Langle. Yeah. So in views of existential and logotherapy too, depression could be actually a way of the body, the spirit, reserving its energy and going into a much needed retreat and place of recovery, because it's expended so much energy that has not been functional anymore. Reaches a point where there's diminishing returns on that. And now it would seem like, oh my gosh, I'm so paralyzed. And in a capitalist society, well, you're not working. That is the worst thing of all. How horrible, right? And certainly we had lots of stigma to that in our society. However, maybe that depression that arises is actually a better alternative than continuing in a frenzied manner.
Yeah. If I need to be depressed, because if I'm not depressed, I would have to be anxious. And the anxiety is actually more difficult than the depression.
And anxiety is a higher risk for suicide, actually. So it makes sense.
That example, because again, it shows the adaptive nature of these, and it shows a kind of dynamic. And I think this is one of the distinguishing factors between a symptom-oriented perspective and a healing transformation perspective. And healing transformation comes from the idea of psychodynamics. A dynamic indicates a kind of bilateral relationship. We might think of the idea of aerodynamics or fluid dynamics in physics. Dynamics refer to the kind of mutual forces that two different sources impact on each other and the kind of relationship that they experience between each other. So a dynamic understanding is a little bit more complex, because influencing one half of the dynamic also influences the other half of the dynamic. But that's often how it is for us, that our psyche engages in this compensatory flow with its different elements in order to maintain a kind of balance or homeostasis. So we can't think of things linearly from a healing transformation perspective. We have to think of things dynamically and in constant flux and compensation.
And that's systems thinking as well.
That's right. That's another term that's often used within that world. Symptom management, though, takes more of a psychomechanic perspective. So it looks like, okay, what is the problem? Yeah, what is the problem, and how can we leverage a solution? What is the basic operating mechanic of this problem, and how do we come in and provide an intervention that fixes it, essentially?
Like a mechanic, a technician.
Exactly. I think I don't know, I don't think we've mentioned this yet, but There's a really popular psychiatrist on YouTube, Dr. K, I forget his last name, but he goes by Healthy Gamer GG. Wonderful media personality, psychiatrist. He makes so much great engaging content. And he spent some time with his viewers once kind of breaking down the distinction between different types of therapy. And he kind of, similar to us, he had kind of an idea of two kind of broad schools of therapy.
Wonderful.
Psychodynamic and CBT. And he described it exactly that. If you go and see someone with CBT, it's a little bit more like seeing someone with a technician, like they're going to just kind of try to leverage a solution. Whereas you see someone psychodynamic, it's more like really understanding the problem, really understanding the depths of it.
That's great.
So here's one of my queries, Richard, as we kind of keep moving into this. What do you think makes the symptom management perspective more attractive? Because I certainly, I don't know if you get the same sense, but certainly my experience of this seems to be the one that people go to in terms of a conventional understanding. It's the popular perspective in kind of media.
It's what's paid for.
Yeah. And even in like in my undergrad, like the psychodynamic theory was a chapter in my introductory class and then basically never touched again. Like I think most of contemporary academic psychology is focusing more on this illness-oriented symptom management style perspective. And so what do you think makes it so attractive compared to its alternative?
Well, I feel pretty confident about this. If we can be a technician, there's a distance between us and the client. There's unfortunately an othering that goes on. There's always a power dynamic, even if you're the most human-centered, client-centered person. However, this increases, I think, the power dynamic. It almost can put you onto, I have the answers and I apply treatment A, intervention 1, intervention 2 from treatment A, and then it should have this result. And humans don't work that way. However, this idea, I get it, to reductionism is very appealing. The idea that we could apply a simple solution like a hammer to fix the car engine. If we could apply a simple solution to fix the problem, antibiotics to like some really powerful bacterial infection, that works, right? Sometimes there is such things, but in the case of a lot of human suffering, that formulation doesn't work so much. But you didn't ask this, but while I was thinking about it, the danger of that too is, you skip out on understanding the functioning of the issue, the function, the purpose of the problem, if it is such problem. And also, in one sense too, I see it actually can be really hard because that was the approach that I took, quite early on as an entry to practice therapist. You're always having to come up with a million different solutions. You're in the chair of an expert. It's very exhausting. And I do wonder, being a supervisor to many new therapists, that if that attitude doesn't maybe contribute to burnout, how exhausting it would be to be considered the expert at all times, and that your clients are failing and they feel they're failing and you feel you're failing because you're not smart enough. You haven't come up with the best formulation, and frustrated why maybe when you do apply it, it doesn't work. There must be something just automatically wrong. What does it leave us with? It leaves us with, I must be a shitty therapist or this client is resistant. And they're a bad client. And I don't like either of those options, those really binary options. And I think they actually increase a lot of suffering. But why it's so attractive to this, why symptom management is so attractive is, again, we don't have to think so much or get in touch so much or have to be immersed in our own suffering or the client's suffering. And so there is that buy-in of, well, I can have some distance. I don't have to face my suffering, and I can, and also even if, could have another view too of, well, if it doesn't work, then I guess it wasn't me, it wasn't our relationship. There was, the formula just didn't work. So I guess we should try this other formula and send them to 5 other CBT treatment centers.
I just really love your answer. Okay. And I didn't actually expect that, Richard. And that's what makes me love it even more because my mind kept going to culture, right? Oh, well, we have this culture, like I was thinking sociologically around like, okay,
Which is great too.
yeah, suffer's got a bad name, right? Suffering has got a bad rap and stuff. But God, it makes so much sense. It's not really about them. It's about us.
Oh, it's about us.
Yeah.
It's not the patient. It's us.
No, it's about us. Yeah. And it's so true. And I love that. This idea that, yeah, like this kind of approach is appealing for us because of what it allows us and affords us. It allows kind of safety in the process and the relationship that really keeps us from having to go to muddy or difficult territory. Yeah, no, I think that makes so much sense. And I think when we were prepping for this, we had kind of touched on that briefly. This idea that when you engage in more of a healing transformation process, one, yeah, I mean, you have to be prepared to go wherever the client goes. You have to be in a position where you're acceptant of whatever the client brings to the session and willing to be with it. And that in and of itself is very difficult because that involves a great deal of personal reflection and your own work and things like that. Right? But you also have to be prepared to deal with ambivalence and resistance on the client's part, right? And I think, that's a complex and challenging, kind of area of therapy that a lot of therapists struggle with, right? And I feel like a symptom management perspective sometimes subverts that because it only aligns with the part of the person that is interested in eliminating the symptoms. So sometimes it never really brings them into a place of conflict in the first place.
Well said. And so I think it's great too. I'm describing our, I guess the intrapersonal dynamic that makes doing symptom management easier, so appealing. I would love for you to talk a little bit more about how society has a problem with suffering, or just let's even call it discomfort.
I mean, I don't know that I could say too much about that, Richard, apart from it seems there is an emphasis in our culture away from suffering. I don't necessarily know where this comes from, and this is worth further discussion and exploration. That it seems like there's a basic emphasis away from suffering that doesn't just translate it doesn't just occur within the individual, but extends socially as well. We think about the fact that in polite society, at least, being too vulnerable or sharing too honestly about one's struggles or strife is kind of taboo. Mm-hmm. If I ask you how you're doing, what are you going to say?
Oh, fine.
Yeah, that's right. And I feel like for me, one of the gifts of this work and this career path has been that I've been able to access more environments that invite vulnerability, because that's just not something that I find out in community so often.
It's a soothing balm.
Yeah. And I think the barriers to that are multifarious. This is partly why I feel the answer is too complex to summarize simply, that there's so many personal, philosophical, sociological reasons that go into this. But, one, we could basically say maybe something like this, that at base life is hard. I always go to this idea that the first thing the Buddha said after his enlightenment, the first noble truth, it wasn't like, oh, hey man, just be happy and think good thoughts. He didn't have good news. He wasn't out there being like, yes, okay, I'm enlightened now. What it is like, you just got to be positive, right? And it's all good. No, the first thing he said is life is suffering. Like life.
It's surprising he had so many followers after saying that.
Sure, are just like, yeah, well, yeah, right. I mean, it's a little bit crazy, but he was like that. That's just it. Is he's saying like life is basically suffering. Like there's a basic experience of suffering that comes with living. And I think that this is just what we do to try to adjust to that. Many ways, conscious and unconscious, across aeons, culturally, we as people have done our best to adjust to this basic fact, for better or for worse, as best we can. And this is I would maybe say this is just where we're at with it, is that we're maybe better than we have been, but maybe still not so good in terms of the kind of room that people feel they can have to be really vulnerable and open with each other. I love there's lots of great cultural examples of this too, about how different cultures approach their own experiences. Yeah. I understand that, here in Canada where we have a reputation for being uptight and really blocked to our feelings. And I think we share that with the British to some degree. But I know there's a lot of other cultures in the world where people are free or feel free to be more evocative and expressive.
Oh, even our American counterparts.
Sure. Yeah. Yeah, our cousins to the south. And so partly we're speaking about our own context here and how we're situated in our particular space. But I think I would imagine that every culture and society adjusts or finds some aspect of human experiencing and human suffering challenging.
Absolutely. And to extend, this intrapersonal example to society, I've always been influenced by Judith Herman's book, Trauma and Recovery, focusing on the denial of trauma collectively in our society.
Yeah.
Trauma, we could, just for the purpose of this podcast, let's make it somewhat interchangeable with suffering. If we, to take a radical social justice perspective, if we were to really acknowledge and feel the level of suffering that oppressed people suffer, BIPOC people, people in challenging socioeconomic situations, other things, many people, that I guess we have a fear that this would overwhelm us, society as a whole. And I think it structures a lot of systems to avoid. So it's not just interpersonal, it structures systems to other the person and give a distance to whole groups of people that either that you're not allowed to suffer, or certainly that we don't see it, or there's something wrong with you for suffering. And it's made very individualistic. You're suffering because you have DSM code 309.28, I don't know, versus we might have to change whole system, how our whole society is structured, if we were to really get in touch with the level of suffering that's happening in the world. Like, just very simple, the idea of child labor, the clothes that we're wearing, every few years there's like an expose about how horrible these conditions are. And then the companies look like they do some greenwashing, looks like they're improving environmental conditions, improving conditions for their workers. And you find out they just hire another subcontracting company and that does worse things and has less oversight. And so if it's out of sight, it's out of mind.
The example you provided is a good one that links us to another important concept that differentiates the two approaches that we're talking about. And that's the idea of levels of order or orders of change. When we talk about taking a symptom management perspective, we're really not talking about any type of change. I think that's one of the hallmarks of that approach. There's this understanding that this is just the way things are, and you do your best to adjust to things and just manage them as you can. There's the, interventions just focus on coping and kind of living with the problem. But when we talk about healing transformation, we're talking about going to the second, third, fourth order change, to higher orders of organization in the system, the kind that create radical change. And you might be the better person to explain orders of change, Richard. But yeah,
actually, I'd love if you did, because I kind of forgot them, to be honest.
Sure. Okay. Well, sure. I'll do my best. I'm referencing Gregory Bateson here. And just the idea that first order change is the idea of changing something within the system that really alters nothing fundamental about it. So if we have a system in place that produces boxes, for instance, first order level of change would be, well, we're going to change the boxes from pink boxes to green boxes. There's change, but there's not really change. It's still a box producing machine. It's a change kind of in appearance only. Whereas a second order change would be a change that really fundamentally alters the functioning of the system in the first place. So we're no longer changing or making boxes. Now we're making shoes. It's more profound, a real type of change that's distinct. And so you and I both know from a systems perspective that second order change is much more difficult to get to when we look at systems, whether interpersonal within families, and I understand your example is going to emphasize that today, or intrapersonally within a person themselves, kind of within the parts of a person in their self system. Second order change involves the radical renegotiation and positioning of these different parts of the system, and is much more complex and difficult to do. But the result is the kind of radical transformation that we're talking about when we talk about healing transformation. When we talk about healing transformation, we're talking about taking a person from a place where they're experiencing a symptom to one where they no longer do at all. Or, and this is an important distinction as well, one where they do continue to experience the symptom, but they no longer understand it as a symptom. It's no longer a problem.
And I love that. And what about third and fourth order?
Well, this is where I think I'm probably out of gas too. I've seen third and fourth order referenced within depth-oriented brief therapy, in reference to one's relationship to oneself. So I'm probably going to butcher this, but look at first order as the basic behavior or the symptom itself. The second order is the set of like assumptions or beliefs that kind of structure the relationship or the production of that system. Third order is, I think it's like a more basic level of orienting assumptions about the world and how it works.
Yeah, I'm seeing here a shift. Third order change occurs when there's a shift in how we understand and relate to sociocultural systems.
Right.
We understand the system we are in as part of a system of systems.
And then fourth order change, at least within this context, would be basic assumptions about oneself. So when they talk about it in depth-oriented brief therapy, they're talking about basic things like, am I good or bad? Like just quite a simple, but quite a very high level. Or we could look at this, because it's depth therapy, we're going down, so a very low level of organization. Yeah.
Well, and it's saying it's even questioning what we think about systems, what we question are the facts of life. It's questioning kind of our core programming seems to be fourth order. It's taking the red pill in the matrix.
Sure.
I like this too in fourth order, this idea that maybe things that we view as threats could be actually, or crises, or could be opportunity.
Yes.
That's very interesting to me.
That was one of the appeals for an approach like depth-oriented therapy for me. One of the nagging things that kept coming up for me until I hit that orientation and discovered it. I would be in a session with a person and I would see them suffering, and I could feel the part of them that was appealing to me to try to find some way to suffer. But there was always a part of me that would show up and sort of go, but how can I help you get rid of this suffering when you don't understand what it really is? When you don't understand what it's really bringing to the table? What if this suffering isn't suffering at all? What if the suffering that you're experiencing is actually coming from a different place? Or just, it was something so basic as that, to kind of have this almost permission to learn that, oh, actually, that's your job, is to really discover the truth of this, the emotional reality where this symptom stems from, and then help the person decide whether or not, from that perspective, it's meaningful to still keep doing what they're doing. That's therapy. That's what's really helpful to people, not just giving them something to mask what will ultimately remain for them until they attend to it. Not just something to soothe the pain that might actually be important to them in some way.
Would be now a good time for me to share how, because we've been bashing symptom management as the worst thing ever, just to give a little bit of nuance of maybe how it could be used in an ethical way.
I think that's great, Richard, because I think, because, you and I have talked about this, and you take a slightly different perspective than I do, and one I appreciate. I'd love to hear more from you about your use of symptom management kind of tactfully in your process with your clients.
So I think sometimes symptom management, and especially when I'm recognizing that I'm in a system, often a system like a healthcare system, I work at a pediatric clinic part of the week, that people coming in, the clients, the doctors, etc., are thinking in these terms, and they may have already been to many through the medical system in many ways. That's many of the clients that I work with, especially in the clinic that I work at. And to completely kind of ignore the idea of symptom management, I think it's almost, they're not maybe ready for that. And so I see symptom management as a door to be able then to move forward into maybe further healing transformation. So somebody's coming in, they are really struggling greatly, let's say, with PTSD, both the child from, let's say, their anxiety, depression, maybe they've been poked and prodded for a medical condition they've had for a long time, even in infancy. Parents are struggling with this as well. Maybe their child almost died. So they have, the whole system is very traumatized. I kind of need to know and use the language of the game before maybe I break it. So I co-opt, maybe I'm a little bit of an insurgent, I don't know.
Mhm.
I co-opt the languaging. So I often speak in pretty biological neuropsychology kind of terms, simplify things around fight, flight, freeze mechanisms, amygdala, etc. Wonderful model of the brain that kids, take apart and put together. And sometimes I do give clients some techniques, whether it's a breathing technique, whether it's behavioral technique like gradual exposure to face anxiety. And this can be actually quite empowering to the client to see that, oh, if I do this thing, yes, it has an impact on my symptoms, but I don't stop there. I think so often as we stop there and we're like, great, I followed the CBT treatment manual and, they have some skills to manage, do some cognitive challenging. They have some breathing skills. They seem like they're doing a little bit better. But particularly as a family and systems therapist, I know that if there isn't higher orders of change, that they may get some temporary relief, but the issues they're facing are really not going to get often, not significantly better in terms of, and even being able to relate to other members of the family, being able to relate to other humans, being able just to kind of function in life, have a meaningful life. I'm not going deep enough. So I may start sometimes with a symptom management approach. And I'm pretty clear with clients in most cases, obviously it depends on the age, because sometimes I work with kids very young, that this is not the end. Okay, I'm giving this to you, but I also think maybe I'm going to be working with you, mom or dad, because there is an understanding and maybe a pathologizing of the child as like the problem case that needs fixing and needs to have a technician to come and fix these things, when actually you're not even aware and haven't even addressed the lifelong history of trauma that's been going on for you. And that is now really impacting your relationship with your child, relationship with others. So yeah, I think sometimes symptom management can be part of what can be helpful, part of a solution, but it's not a whole solution. And we have to really be careful to view it not as the end goal.
How I'm hearing it for you, Richard, is that this willingness to utilize even just the language from the approach or anything from the approach is done so from a place of honoring the need to engage the client and kind of operate within their terms of understanding and create, structure a process that is accessible to them and makes sense. And I really see that as valuable and essential. And it speaks to your values as a therapist. I love it. I think it's a great example. It speaks to the broader need too, that, in the context of healing transformation, that what we're doing is we're really asking people to go to the most painful places in themselves. And that's a tremendously difficult thing to do. And so in order to do that, we have to have a kind of permission from the person that we're working with first to kind of go there. And B, we have to be sensitive to their capacity to tolerate that.
And I also know, because sometimes clients will come in, families will come in, and they're really like, give me the techniques, give me the strategies. And I'm very careful actually to slow down and be like, we don't even know what's going on in the child, in the family system, right? Slowing down, getting a thorough history, getting a thorough understanding, so right now, maybe the child is having a panic attack so severe that they're maybe throwing things at the wall or hurting people, hurting themselves. And you're saying like, well, can you just teach me a technique? How do I get rid of this? It's that symptom management, reductionism to the extreme. There's so much pressure. And I can see this in my practices I work with. They're like, well, I'm not giving, what the, maybe there's pressure on the student to give what the client wants right then. And the client is, always right. But no, actually, as an experienced therapist, I know there's the problem that the client knows about and is the presenting issue. And then there's actually the root issue underneath. And so, to give them the same too, right? It's very tempting. Oh, okay, yes, I'll just give you this other technique because I know so many of these techniques. But I also know that's the same thing that they got from another therapist and it has not been helpful. And they'll often say that, oh, well, we went to this other therapist and we learned all these breathing techniques and we learned all of this.
Yeah.
And so we have to understand the function of the behavior. We have to understand, so sometimes they do a functional behavior analysis, but also like there might be traumas, there might be community, familial, relational, spiritual dysfunction and suffering that's happening. And there's a need. I also talk to the parents a lot about, so if I give a breathing technique to this kid when their actually need is, I need space or I need to be understood, I need to be validated. And I'll go into another example later about that. A breathing technique and kind of like just breathe and deal with it on your own, especially if the attitude we have to symptom management is very important. So if we take that very individualistic deal with it on, which happens so much, and I'm often, my work is undoing that with families, that this is more of the same and this is not helping.
There's a whole emotional reality where what's going on actually makes sense. And getting people there is the challenge. I've had similar experiences, Richard, that have been pretty difficult. And I've blundered some of these sessions even. I'll be honest with that, where people come in and within 5 minutes, it's like, yeah, I'm depressed. And so do you have any strategies for that? Throws me off. Puts me in a position where I feel like I need to be taking the expert position that we talked about. It can be very difficult to talk people to a place where they understand, oh, yeah, this is really still about me. This is, as much as you're here to help me, you can't do for me what I need to do for myself. This leads me to a quote from Macbeth, which I think summarizes this really well. I saw this referenced in one of Thomas Saz's articles. Thomas Saz is a relatively well-known anti-psychiatrist, and he was making reference to, again, how the medicalization of suffering kind of obfuscates its true nature, and it obfuscates the role that the patient has to attend to themselves and the role of the doctor. And I think that this was something that was very fortunately impressed upon me earlier in my supervision, and that I hold true to now, that we can only ever really be a kind of companion to someone else's experience. We can never really do for them what they need to do for themselves. And so the example is Macbeth, the patient, if you will, concerned about his wife, doing what I imagine so many of us would do during a situation of profound suffering like the one that they were in. And he goes to the doctor and goes, "How does your patient, doctor?" And the doctor says, "Not so sick, my lord, as she is troubled with thick coming fancies that keep her from rest." And Macbeth says, "Cure her of that. Canst thou not minister to a mind diseased? Pluck from the memory a rooted sorrow, raise out the written troubles of the brain, and with some sweet oblivious antidote cleanse the stuffed bosom of that perilous stuff which weighs upon her heart." And the doctor says, "Therein the patient must minister to himself." Macbeth, the ultimate resistant client.
Maybe some sociopathic tendencies, but
well,
we're
sure,
not going to pathologize.
That's
He's already been pathologized enough.
Sure, but the situation he and his wife were in were certainly
there's suffering in every angle, and Shakespeare being a master of understanding human suffering and tragedy.
I can't really blame the guy.
No.
Why don't we move into our case examples now,
let's
Richard?
move into.
Talk a little bit more about
the lightness of Macbeth makes sense.
Sure, yeah. The example I have is a pretty simple one, but I like it. And we talked about that maybe it's a good one because it illustrates that even when we talk about healing transformation and kind of a more profound adjustment, like a more radical adjustment within a person to resolve a symptom, that sometimes we assume that this needs to happen over a long period of time, that there's a complexity of the process. I certainly think that's true. Certainly think for many people, there are long-standing patterns that are not amenable to brief change. And so I don't want to sell people on the idea that that's not the case. But I like my example because I saw this patient 3 times, and actually just recently we had a 4th session booked actually, and just recently, and they canceled it. And I actually think that's a good thing because I think that they canceled it because they don't really need to come and see me anymore. So if they do see me again, that's fine. And I'm sure that's because there's more to talk about, but things moved pretty quickly for this patient, which was pretty cool. So this is a patient who was diagnosed with cancer and came to see me for a first session, I think just shortly before or very shortly after starting treatment, which is often a place where patients experience high distress. I mean, cancer treatment is really, really awful on a good day. And so patients are understandably distressed during treatment. It can bring up a lot of anxiety. In this case, though, this patient, when they came to the session and they came with their spouse, they were so distressed. Like they were crazy distressed. Like they were like very evocatively distressed through the whole session, kind of flooding the room with distress. And this was something that I don't actually typically encounter. Normally people's stress is a little bit more contained, or something that we have to dig for a little bit sometimes. Sometimes it's behind layers of defense because it's so difficult. So it was interesting to me that this person's distress was kind of bare and out in the room, and kind of even like I almost felt really pushed out there. And this feeling is important as I talk about this example. But yeah, they voiced anxiety, difficulty sleeping, feeling overwhelmed and concerned about the life-limiting nature of their illness, and just in general feeling awful and like they didn't want to be in the position that they were in. So let's start with a symptom management perspective, break this down a little bit. If I were to take that perspective, the primary thing that I would be focusing on is the fact that the person is distressed and the need to help provide some alleviation to that distress. I feel like it's such a trope in our world, this idea of breathing. Everyone wants breathing techniques. Breathing techniques are advertised everywhere. There's like a million breathing techniques. And that's where my mind would go, okay, we're going to go to breathing. And if not breathing, then maybe we're going to go to something like CBT. So we're going to try to look at, okay, what is the person afraid of? What is the thought that they are having? And how can we provide a counterexample thought that is more rational, less distressed, more self-compassionate? There's nothing wrong with that. There's nothing wrong with that position. I think that the patient might have appreciated a kind of gentle or supportive attention in that sense. But how I saw it, how I still see it, is that there was a reason this patient needed to be distressed. And in my perspective, not even just that, but there was a good reason that they needed to emphasize their distress, because that's really how it came up in the session, right? I'm not just distressed. I want you to know I'm distressed. I want you to see how distressed I am. I want to make sure that this distress, can't be missed. And I certainly got, okay, there's a strong emphasis on this distress. And for me, where I go from a healing transformation perspective is, I wonder if this distress is so strong because there's actually a downward pressure that's trying to keep it contained. I wonder if actually it's so difficult for her or for them to be distressed because because there's an equally large part of them that's trying to prevent the distress.
Yes.
Dynamic is perhaps fueling some of this.
The judgment about being distressed as well.
For sure. So in our second session, because the first session was really just more of a get to know you and a basic sense of empathy and the basic rapport building. Mm-hmm. And in our second session, though, we really started to talk about more about their experience of distress. And I started to try to explore some of the meanings and features of this distress and just their experience in general. And what I learned was that this person actually voiced a longstanding pattern of self-sufficiency, understood themselves and their family system to be like a provider and a strong caregiver and like the support of others and kind of the rock of the family. And in general, found it very, very difficult to be sick because of the way it might compromise them in these important roles and in this pattern that they understood themselves in and that they found comfort and familiarity in. For them, being sick and more importantly, and this is what really became challenging for them, was to kind of express their vulnerability to other people and to kind of need support was really, really difficult. That was the downward pressure. It wasn't so much that I am distressed and that's the problem. It was that I'm distressed and there's another part of me that feels I can't be distressed.
Because I won't be able to care for others sufficiently.
That's right. Yeah. And so funny enough, my intervention was a fairly basic one, but it was just to ask them to admit their distress. So I simply asked them to say in the session, can you just say, I'm not doing well right now? Like I'm having a hard time right now. Mm-hmm. And they tried that a couple of times. And what's funny is it was like a pretty quick transformation. They were just like, oh yeah, I'm not doing well right now. And it was interesting to watch. A part of them really kind of embrace that truth in them. I'm struggling. I'm really, really having a hard time. I'm really distressed. This is not okay with me. And so we wrapped up that session. They said, okay, I'm feeling a lot better actually, having said that. And I thought that was great. Okay. And maybe there will be more. So we booked a follow-up session. I was encouraged to see that was meaningful to them though. And in the next session, they came back and it was like talking to a different person. It was like they weren't distressed at all. They had no distress. It was profound, actually. I kind of couldn't believe it. just because I thought there would be more. I thought,
Understandably.
I didn't think that this would be the end of it. But it's funny because I think in some ways explicitly they didn't really ever understand all that I voiced, and perhaps my formulation, at least. I didn't get to a place with them where I was providing any type of interpretation of their experience, or where they were really deriving a new conscious understanding of themselves that they didn't already have. But they said to me that they just kind of realized that they needed to let some things go. And that was the change for them. Because I explored that. I said, wow, you're so different. How is it that you're so different now? And they said, well, I realized I needed to let some things go. And how I understand that is that in stepping into the distress and in giving it, in actually owning it and allowing it, like through the experience of admitting it, that they were able to reposition themselves and appreciate that their distress is something that they can experience, and that it doesn't have to be a liability or a problem. And that my understanding is that it must have been that the downward pressure, this repressive force, this tendency, or this kind of vulnerability blocking part wasn't that strong, because I imagine if there had been more behind that, or if there was more invested, it would have had to dialogue more, right? That would have been,
for sure.
There would have been more complexity. But there it was. I mean, it was as simple as by allowing the person actually to own their distress, as opposed to trying to repress it further, that it was transformed. And
suffering begs to be acknowledged.
Yeah, I like that quote. And then we had a bit of a nothing session. So for the rest of the session, it was kind of like talking about whatever. And then again, they've canceled their last session. And
fair enough.
If my sense is it's probably because they're doing okay, which is great. So that's my example. I like it because because it's simple, but it shows the paradoxical kind of agenda of a healing transformation, that we have to go to the place that the person feels they can't, and that's where the healing happens.
That's right. And it helps when we can be there with them, and they know that we're willing to, and we're not afraid to bring it up. And it brings up like some Buddhist principles too, of paraphrasing a lot, but like what we resist persists.
Yeah.
And so they're resisting, this can't be sick, it just doesn't fit my reality. So it sounds like in a lot of ways you got to at least third order change there, that they're questioning some of the assumptions and facts of life and relational dynamics of the system that they're in. And again, they don't need to read a treatise on systems thinking to get that. It's a felt sense and experience that can be as simple as, again, shining that light, acknowledging that suffering.
Yeah, for sure. That's really my focus more and more as a therapist now, is structuring experiences. I explain very little in my sessions. I tend not to labor the information, but
it's wonderful.
You triggered up something in me that I'd want to say before we shift to you, but I don't know if it's there. What we resist persists. Yeah. Oh, yeah. Just the idea that, like one of the hallmarks of this approach is appreciating that people are a multiplicity in their experience, that they can have conflicting positions within themselves around a situation. The symptom management perspective tends to view people as having a kind of unimodal mind. We're of one mind about things. We just have the one mind. But in a lot of psychodynamic positions, there's the idea that people can have many minds and can feel different ways about things, and that often it's conflict in their experience that creates the problems that bring them to psychotherapy. So for me, that's just part and parcel of working with someone's understanding that they might feel two ways about one thing.
I delivered a lecture pretty recently on internal family systems, and of course there's nothing new under the sun. It's coming from a great richness of psychodynamic work, parts work, ego state work, etc. But I do like its very simple explanation of basically, and it's so non-pathologizing, of that we can have a multiplicity of parts and of selves, and that just acknowledging that we have this part can help, right? Whether it's soothing or reduces distress, or just is validating to oneself. I have a toddler, so I know that talking about what resist persists, if I stay on my phone and he's saying, daddy, daddy, he's going to escalate in his cries. He's going to try maybe some more difficult behavior, let's say, to get my attention. So, what an great example of having a survival adaptation. The symptoms increase in volume, again, if they're even really symptoms, until we acknowledge them.
Yeah. I love your reference to internal family systems, Richard. And I would love to hear from you now about your real family system that you worked with, your external family system.
Yeah.
In your case example.
So both of these cases are what we call somatoform. So the body, in really apparent ways, taking on great distress, again, in a very apparent way. So in one case, several years ago, I'm thinking about a child in primary school, and she presented with basically paralysis in her legs. So it was getting to the point that at first it was kind of partial or popping up sometimes and disappearing at others around school. And so she had no problem at the original part of treatment or just before treatment of on the weekends, getting around, walking around, playing with her friends. And then when she was being driven to school, as soon as she just couldn't get out of the car, and literally it wasn't like she was saying, no, I hate school, I don't want to get out. She actually didn't have, even for somebody that young, had very little insight about what's going on. And so did the family, which often is the case in somatoform, is that we don't have a good ability to express our emotions and our somatic sensations. So it can be a very, very concrete kind of understanding of things. And we lack that maybe deeper nuance. So it's hard. It's a lot of suffering because we have a hard time being able to describe what we're experiencing. But in any case, she needs to be carried to the school. So the school now is like making these accommodations that basically she's being wheeled around in a wheelchair. Of course, they consulted with BC Children's and Somatoform Clinic, and they got a full medical blood test, brain scan. They got all of this stuff. They were really good advocates. It's sometimes hard for patients to get all of that. But in any case, they were getting those things. And of course, it was coming back like, well, actually, she's like physiologically, organically, there's nothing wrong with her. And so it was hard. They're like, where did this come from? Where did her daughter, we're kind of losing the function of her daughter. The paralysis is getting more frequent, so that it's like now extending into the weekends. It's now extending into other areas of her life and more like almost like full body and almost like to a catatonic state by the time that basically she's presenting in my office. Really concerning. The case manager that referred was just like really, distressed, I think, for the family, and was like, oh, I don't know what we can do. And they've seen all of these different people. And at that time, I was really deep into existentialism. I was really deep into also a lot of EFT, of emotionally focused therapy, of understanding the impact of attachment and relationality and validation. And as I got a history, I learned that her teacher in a previous grade was not like a horrible person by any means, but was a very strict teacher who kind of just didn't acknowledge much about emotions, kind of saw this kid as like, when she was expressing a concern, expressing a feeling, as dismissing it, or is it not really real? And like, she was saying, I'm having some trouble with some classmates. And they're like, well, you kind of just have to get used to it. Girls will be girls, boys will be boys. And so, especially so paired with this interactional effect of the child being already what we might call an empath or a highly sensitive person, and then a teacher who was very old school, let's say, and very dismissive, it created an invalidating environment. And so what we learned was really my body, my brain, myself, my core is kind of needs to scream out so much by these very apparent symptoms. Like you can't get much more apparent than literally showing up to your therapist's office or to school, like catatonic, essentially. Screaming out to be validated and screaming out to be acknowledged, because she herself as a young child, and so we don't listen to children enough, didn't have a voice for these things. And so we started to learn this. The teachers, the parents themselves were like, well, seems like the environment, in this other grade was harder, but, can't be that bad. And then as we got into it, I'm like, this is what it is. And listening when the child was able to open up a little bit and kind of nod to some of the questions I asked, it seemed to me that this was, in my case, conceptualization, that this was it. So it really was about almost nothing else except saying, it's understandable that you're feeling this way. It's understandable that your body would need to express that, and also helping the parents manage their reactions from it, taking it like that this is some horrible medical, disorder she's going to have long term, to this is what she needs to express right now, and not try to be like, well, you need to get your butt moving. So just that's what she's expressing right now. And so really focusing on validating her experience, validating the pain she's being in, the pain of being invalidated. She was also developing like physical pain, I think, from this too. It was coming up quite severely. She would talk about at times, and it was amazing. It started to change from a situation where, again, you have some of the top experts in Canada kind of feeling like, I don't know what we're going to do about this situation, and the parents are like, well, I guess we better go buy a wheelchair, essentially, to a lot of hope, as the change didn't happen right away, but it was a little bit of like, this symptom, let's say, or this survival adaptation isn't needed so much anymore. And so I don't need it if I know, and we talked about predictable attachment time with the parents, where it's just literally doing some rice tray work where she gets to kind of be the boss of the rice tray and kind of share her feelings or share her world or whatever with the figurines in the rice tray, non-judgmentally. They're just empathizing with her because her need was validation. It was lacking. So they are giving what some adults were not able to give in the past. And so they really jumped the task well. And she was able to, by the end of therapy, within probably 6 to 9 sessions, let's say, she was walking, running. Because the other thing was, she was isolating more from peers. Peers also didn't know what to do about this. Didn't make sense to them that she was now socializing better. She was expressing her feelings. And so they could also see when it was coming up earlier and not freaking out about it and being like, okay, just instead like, what do you need right now, daughter? And it was really, by the end, I think we were all having some tears to our eyes and like the level of change. And there was an understanding more. The whole family, it wasn't just enough for her too, to be like, I'm seeing my feelings. I said it's very important to the family, to the parents, that you need to be the ones modeling when you're having a hard time. I'm having a hard time. I'm feeling sad. Mommy or daddy needs to, maybe it was take a breath, or it was like, mommy or daddy just needs to look at what I need right now. Mommy or daddy need whatever. So look at the need, look at the feeling, meet that, and connect with each other, and not stigmatize emotions or somatic sensations and amplify the nervous system's alarm signal.
Wow. What a great example, Richard. First of all, I want to just acknowledge how challenging that must have been to work with a somatoform disorder, something that my understanding is can be quite complex and challenging, and kind of demands the approach that we're talking about tonight. There's no real way to symptom manage your way out of a kind of unconsciously produced paralysis. You're not going to breathe your way to that one. And so kudos to you for spending the time and exploring with the patient and the family, or the client and the family, the places where this might be necessary. I love that's what you discovered, that for your young client, it was really, if I don't demonstrate my distress through this paralysis, through this intensified kind of physical disorder, can't be seen at all, or it won't be seen at all. And so I love that there was just a great deal of validation around that as the primary intervention that shifted the focus from this is a problem to this is a solution to a different problem.
Yes,
right?
Correct.
Yeah. And I love the way that you incorporated the family system to not just have it be the responsibility of the client to shift, but to acknowledge the parent's role and responsibility in transforming their relationship with their daughter in a way that supported a new solution so that the old one was no longer necessary.
Well, thank you. And what a great summary.
Yeah, just beautiful example. I think we're getting close to our time, Richard. This is what I say at the end of my sessions with my clients. But I got to say, this was a gratifying conversation to have tonight. I just feel really great that we were able to talk more with our listeners about how we understand psychotherapy as a meaning-oriented process that is meant to elucidate the humanity of the client as opposed to obfuscate it.
Oh, yes. I love that as well. Thank you. Yeah. I don't know. Just thank you.
You're welcome, Richard. All right. We'll wrap up. Take care.
Take care. We hope you enjoyed the podcast and are a little wiser for it.
Thanks for listening.